Hello, welcome back. It's Elizabeth. Today we are going to cover hypothyroidism. Okay, we got our patient concept map here to do that. And as we usually do, we're going to go ahead and start with the patho. So the patho of hypothyroidism, and if we remember, hypo means low, so low thyroid. Okay, and first of all, I just want to review your thyroid is located in your neck. Okay, so just kind of right here, just kind of over the voice box area. That's where that lives in your body. And the thyroid controls your metabolism. So the way that your body processes food for energy. So the thyroid hormone, the hormone that's secreted by the thyroid, affects every cell and every organ in your body. So whenever this particular gland gets out of its normal process, it causes a lot of problems throughout the entire body. So the patho of hypothyroidism is decreased or absent secretion of thyroid hormone from the thyroid gland, which results in a decreased metabolism of the entire body. So the most common causes are autoimmune. So your body starts attacking the thyroid itself, and this is referred to as Hashimoto disease. So if a patient says they have Hashimoto disease, they have an autoimmune form of hypothyroidism. And then another really common cause within the United States is a thyroidectomy. So someone has to have their thyroid removed for various reasons, and so then that thyroid can no longer produce thyroid hormone. So then the person becomes a patient with hypothyroidism, and they have to take thyroid hormone replacement medication for the rest of their life, because it is, vital to survival to have thyroid hormone. And if they don't have a thyroid to produce that hormone for them, they have to take it orally. And then more of the patho is it is a lack of intake, can be caused by a lack of intake of substances needed to produce thyroid hormone. So iodine is a common one. And this isn't really that common in the United States because we have iodized salt. So all the salt that we have, the majority of it that we have available in the grocery store, it's iodized. Okay, so it has iodine in it. And as we know, in the United States, we eat lots of salt. So it's not really a big issue of lack of iodine intake in the United States, but in other countries, we may not intake enough iodine, and that causes another form of hypothyroidism. So that's just something else to keep in mind. And then also, I wanted to just discuss a little bit how the thyroid works. So I already said the thyroid hormone produces the thyroid. So I already said the thyroid itself, the organ, the gland that's within the neck, it produces thyroid hormone. So that is T4 and T3. Those are the main thyroid hormones. So this little organ right here produces that, and when it's not producing enough of that, so those hormones just are not, for some reason, being produced, one of these reasons that we discussed over here, not being produced by the thyroid, then the anterior pituitary recognizes that the thyroid is not making enough thyroid hormone, and the anterior pituitary, which is located in your brain, it releases something called thyroid stimulating hormone, or TSH, okay? And it starts really pumping that out. It says, oh my gosh, we don't have enough thyroid hormone. I need to tell the thyroid to give us some more hormone. Okay, so in hypothyroidism, as we'll discuss in a moment, the thyroid hormones, so the TSH and the T4 are low, and the TSH is high. Okay, it's called a negative feedback loop. And so it can be kind of confusing, but just always know that if you're measuring the thyroid function, you're going to use those thyroid hormones, T3 and T4. So if they're low, it's hypo. If they're high, it's hyper. Okay? So I always kind of think of it as the thyroid hormone, when it starts to kind of wuss out, it's not doing what it needs to do, the anterior pituitary in the brain, it whips the thyroid. So it's like it starts sending out that TSH. Give me more, give me more, give me more, give me more. So it's like whipping the thyroid to try to get the thyroid to produce more thyroid hormone. Okay? So that's kind of how I remember that. All right. And this is most common in women, okay, ages 30 to 60. Okay, so this kind of develops in women typically. Now, men can get hypothyroidism, but it's super common for women to have it. Okay, so now let's move on here and talk about our assessment piece. So the thing that I said before about how this affects everything in your whole body, because of that, it causes a lot of symptoms for the patient, okay, and a lot of things that we might see on the patient. So we said it's hypo, so it's slow. And I don't know if you noticed up at the top, but I had a little sloth, okay? Just to remind you, hypo, everything is slow. We're kind of going into sloth mode here, okay? So fatigue, the patient feels tired. So they might be sleeping 16 hours a day, 20 hours a day, but they still just feel like they cannot get enough rest. All right, and then the patient has weakness. So it's a generalized weakness, it's both sides of their body, upper and lower extremities. They just feel like they just can't get anything done, like they just don't have the strength to do things. Also, the GI system kind of slows down, so then they develop constipation because nothing's moving. So we're just, we have constipation, which can lead to like abdominal distension. We have cold intolerance. So they always feel cold. They could have 5 blankets on and, 3 layers of clothes, and they just still feel like they're freezing all the time. They have decreased libido. Libido is sex drive. So, it's another thing that is really slowed down in this patient is their libido. They may develop a goiter. Okay, not everybody who has hypothyroidism will have a goiter, but it is something that can develop. And we also actually see this in hyperthyroidism, okay? But it is one of the kind of classic things to kind of know about hypothyroidism is the patient can develop a goiter. So here's an example of a goiter. And we said the thyroid was kind of located here in the neck. And you can really see that this patient has a lot of fullness here in the neck, okay? So that's something to watch out for in our patients diagnosed with hypothyroidism, or for assuming a patient may have hypothyroidism, they may have a goiter. Menstrual changes, so this could result in both extremes for this particular patient. They may have really heavy menstrual cycles, or they could also develop amenorrhea, which is no bleeding at all. So it could be either extreme for the hypothyroidism patient. And then generalized edema, so just from like generalized fluid developing, it just could kind of be all over. So that's something to watch out for. Tongue thickening, so the tongue is now thicker than it typically would be. Bradycardia, so my heart rate is now slow. My body temperature is slow. So just kind of affecting my vital signs. My heart rate, my temperature, my blood pressure, all of that might be lower in a patient that has hypothyroidism. The hair becomes coarse and dry and brittle. The skin becomes very dry. They may get scaly skin from just not having the moisture in their skin that they normally have. I already said constipation. Weight gain, so they're eating maybe even less than they normally eat, but they're just gaining weight. Their metabolism just isn't using their food for energy like it should be, and so that is just sitting on the patient. They're just obese. They usually become, they have significant weight gain. their deep tendon reflexes are decreased, and then they develop depression. And it's not necessarily like, oh my gosh, I'm gaining weight, my skin is dry, I'm constipated, I'm tired. That's leading to depression. It's more of, it's actually affecting the hormones that regulate your mood. So they develop depression. And that is a common reason for people to seek medical care, is that they've developed depression. So that's something that should be screened for in patients that are presenting that are just newly developing depression. So the tests, we had talked about this a moment ago, they will have decreased T3 and T4 levels. So these are labs that we can draw. We can draw T3 and T4, okay? And those are blood levels, and they're going to be too low, okay? And then the TSH levels are going to be high, okay? And that is the thyroid stimulating hormone. So that is going to be the pituitary gland producing that and trying to tell the thyroid that we need more hormone. Okay, so the decreased T3 level, the normal T3 is 70 to 205, okay? And then typically, there's a couple different ways to measure T4, but typically we measure it as a free T4, okay? And the normal for that is 0.8 to 2.8, okay? So that will be low in hypothyroidism, and the TSH will be high in hypothyroidism. The thyroid stimulating hormone, and the normal for that one is 0.325. All right, let's go ahead and move on over here. Talk about interventions. Okay, so the biggest thing that we're going to do for these patients is replace their thyroid hormone, okay? And levothyroxine is the most common form of thyroid hormone replacement medication that we use, okay? And we want to start this at a low dose and increase it slowly. We don't want to kind of give this in a high dose and all of a sudden, really impact all of these different hormones in the body abruptly, okay? So these patients are often going to have bradycardia, hypotension, some of those things. And so if we give this in a really high dose and all of a sudden now my heart rate goes from, 54 to a normal 88, that's just quite a jump. So this medication does directly affect the cardiac system. So we just really need to start it at a low dose and increase it slowly. Okay, and then this medication takes a while to work, so it doesn't work like super quick. So we have to monitor the levels of the thyroid so that we can see how this medication is working. So it's probably going to be like 6 to 8 weeks down the road. We're going to recheck your TSH and your T3, T4 levels and kind of see where you're at, and then maybe make another slow change on your medication. And then mixed edema coma, which we haven't talked about that yet, but that's your extreme worst case scenario situation with these patients, and it requires extremely aggressive management. Okay, so let's just take a look at that and see what that's kind of going to look like here. So if my patient has mixed edema coma, okay, the most severe form of hypothyroidism, my hypothyroidism was not treated, it was not managed well, and now it's gotten to the point that now I need aggressive resuscitation, okay? And we're going to talk more about it in the extreme section, but the medications or the interventions that we would do for a patient that has mixed edema coma would include IV levothyroxine, okay? So the oral form takes longer to kind of work, and this patient may have reduced level of consciousness, so we're going to treat them with IV levothyroxine. We're going to make sure their airway is open. They may need to be intubated. They may need IV glucose, IV corticosteroids, They're going to need hourly vital signs, maybe even more often than that, depending on how they're doing. But measuring their respiratory rate, blood pressure, heart rate, and temperature. They're probably going to have a decreased level of consciousness, so they're going to need to be turned every 2 hours so that they don't get skin breakdown. They already have some edema, which is already a risk factor for skin breakdown. So we just want to make sure that we're taking care of them and not letting them get a pressure ulcer. They're going to need to be on aspiration precautions because they may have such a decreased level of consciousness that they're not protecting their airway. So they could be a high risk for aspiration. We're going to give them some warm blankets to try to increase their body temperature because that's going to be pretty low. And then we're going to do neuro assessments to just kind of see how they're doing, okay, how they're improving or not improving, okay. And here we are over here on this extreme, which is the next section that we're going to discuss. And this is it, this mixed edema coma that we've already been talking about. Okay, and this results from untreated hypothyroidism. And here's our patient, they're not really conscious, okay? And they have dangerously reduced cardiopulmonary and neurostatus. So they're going to be in really bad shape. Really low heart rate, low blood pressure, low respiratory rate, low body temperature, decreased level of consciousness. They may be comatose. Okay, and so the big problem here is this decreased gas exchange. Okay, if we don't have gas exchange, we got big problems, right? And then this can also lead to organ failure. So this is a very serious extreme of this illness, hypothyroidism. Very serious extreme, okay? It's not super common, but it's always something to watch out for anytime we have somebody that's got hypothyroidism, a risk we need to watch for. Okay, so our nursing diagnoses for hypothyroidism: decreased gas exchange and decreased perfusion. Okay, and then here we have teaching. So they are likely to need thyroid hormone replacement medication for the rest of their life. Okay, so we talked about if somebody has had their thyroid removed, yeah, they're going to need to take levothyroxine forever. If they have Hashimoto disease or autoimmune hypothyroidism, that's probably not going to resolve, and so they're going to have to take this medication forever, okay? And then something that's super important is for them to know, the patient, they need to know what the symptoms of hypothyroidism are, and they also need to know the symptoms of hyperthyroidism. Because if I am taking thyroid replacement hormone, if I'm taking that every day, and for some reason the dose that I'm taking is too high, now I'm going to start to develop symptoms of hyperthyroidism, okay? So everything's going to be going too fast, and that can be dangerous as well. So the thyroid really needs to be regulated at a very steady state. So the patient needs to know what to watch out for, because either their medication, they're not getting enough of it, or they're getting too much of it. They need to know that. They will be getting periodic blood tests, so they will be having that level monitored, but they're not going to do that every day, right? It takes several weeks for this medication to work. So, in between getting the testing done, they're going to need to watch for those symptoms. Plus, once we kind of get somebody steady, we may not check the levels as often, so they need to be keeping an eye out for symptoms of hypo and hyperthyroidism. And then they need to consult their primary care provider if they plan to take any over-the-counter medications. Different medications could interact with their thyroid hormone replacement medication, their levothyroxine. So they need to just double check and make sure that it's safe to take over-the-counter medications. They should increase fluid and fiber intake to combat constipation, okay, if they can kind of do some of their own things, having a high fiber diet. And then levothyroxine needs to be taken on an empty stomach without other medications. And as I kind of alluded to earlier with over-the-counter medications, some of the vitamins delay absorption of levothyroxine. So they definitely don't want to take it with vitamins. We really just suggest taking it on an empty stomach, like first thing in the morning, get that one done, and then after that, a few hours, take the rest of your medications. And then, as I've also alluded to a few times here, levothyroxine takes time to work, so improvement can take weeks. So they just need to keep in mind that it may not be, super quick to get the exact results that we're looking for. So I think that pretty much sums up everything we need to know about hypothyroidism. So I hope everyone learned something. Thank you.